Hello, everyone. Welcome back to Karan Academy. My name is Karan. I hope you're all doing super well. For our third lecture of this series, we're going to be talking about nephrolithiasis or kidney stones. So starting off nice and easy, what are kidney stones? Obviously, these are composed of various crystalloid or organic substances. The way we get them is that usually these substances are meant to be filtered out through the renal tubules and just pass in the urine. But if they are present in a high enough level, they often just combine and form crystals that are too big to pass either through the tubules or eventually through the ureters, which is where we find most of these happening. They're relatively common with the overall lifetime incidence of about 5 to 10%, and they are more common in Southeast Asians. Some other risk factors include being male. The exact reason is not known. Renal failure, because again, with renal failure, you lose the ability to produce high levels of urine, which is why often you have difficulty concentrating urine and you have a higher predisposition to generate these crystalloid or other organic substances that form these stones. Pregnancy is another one. Gout, the reason you get gout, and you get mostly uric acid-based crystals with gout, as you know, and that can again concentrate after the tubules and form these uric acid crystals. Dehydration, again, if you don't have enough water, you're going to have more crystalloids precipitating out and then having UTIs. In particular, we talk about one particular organism called Proteus mirabilis that puts you at a higher risk of a certain kidney stones called Staghorn calculi. And we have a picture of that in a bit. So what kind of stones can you exactly expect to see? From a clinical presentation point of view, all of them are going to present very similarly. There are a few nuances between each one of them that are, I guess, relevant from a diagnostic perspective as well as from a treatment perspective. Calcium stones are the most common type of stones, and they tend to be radio-opaque. What I mean by radio-opaque is that they will commonly be seen on an X-ray or a CT. This is different to other stones, which may often not be seen on such imaging. They are mostly idiopathic, but can be seen in states of hypercalcemia. So if you have high levels of calcium in your blood, you're going to be filtering out a lot of that as well. And with that high level of filtration, you can obviously see calcium crystals in the urine, and eventually that can lead to calcium kidney stones. You can also have magnesium ammonium phosphate or struvite stones, and these are the stones that are mostly seen in pyelonephritis caused by an organism called Proteus mirabilis. Proteus mirabilis generates these stones in a special way. What's special about this bug is that when it performs its normal metabolic functions, one of the major byproducts it also generates is ammonium ions. And these ammonium ions latch onto magnesium and phosphate to form these special crystals. And these present with Staghorn calculi. These are huge stones. And then we have uric acid crystals, which are the least common one and are associated with two conditions, gout and tumor lysis syndrome. Tumor lysis syndrome is typically seen where we have widespread breakdown of cells. And this is quite commonly seen with certain tumors, especially hematological tumors. As we break them down with certain medications, you can see a high level of cell death, and that's associated with the release of uric acid, release of urate and uric acid, which once filtered will lead to uric acid stones. One point I'd like to talk about at this stage would be the radio-opaque point I mentioned. Now, when it comes to investigating stones, there are a few modalities of imaging we may use. We can use X-rays, we can use CTs, and we can use an ultrasound. And this is partly where each one of these becomes a bit relevant. So an X-ray, as you know, is a very simple test to do, and it's probably the easiest after ultrasound potentially to do. Calcium stones can be seen on an X-ray while the other two can't because they aren't radio opaque, right? The thing with ultrasounds is that if the stone is big enough, yes, you could see it, but an ultrasound isn't able to visualize the entire ureter super well. That's the drawback of ultrasounds. The drawback of X-rays that you can't see all three. Now, CTs are really, really good. Now, as you know, CTs will pick up radio-opaque material, so calcium very commonly will be seen on a CT. However, these other two stones, although won't light up you can still visualize the entire length of the ureter. And if you look close enough, you can see that there's something obstructing it, although it wouldn't light up with bright white features or wouldn't look hyper intense as a calcium stone would. A CT should still be able to pick up the remaining two, right? Which is why the CT or a CT KUB or a CT of the kidney ultrasound bladder is the best investigation, you can order for kidney stones. And here are a few examples. So the one I'd like to focus on in particular is this one. So as you can see, this is a huge stone, and this is what's called a staghorn calculi. And as you can imagine, really hard to get it. You can't just pee it out, right? So it's going to be managed quite invasively. The other thing I want to point out is that these do not look pretty. And they look like the Windows computer game, not Minecraft. The name's fleeting at the moment. Minesweeper, that's the one. Minesweeper. These look like mines, and that's how these remind me of the Windows game, good old days. Moving on. So in terms of where actually these stones tend to be stuck, you have 3 points of constriction of the ureter, which is where these stones will most commonly present, because obviously they're going to be stuck at the narrowest point of the ureter. The 3 ones relevant to know would be the ureteropelvic junction. So this is the renal pelvis, and this is the ureter. The junction is called the ureteropelvic junction because you have kind of a wide lumen here, which then narrows quite rapidly. The second is when it crosses the iliac artery, and this is mid-ureter, right? So as it crosses, it slightly presses on it, which is why you can have stones stuck here. And the third point is at the ureterovesical junction as it's entering the bladder. What's also relevant to know is that if you were to have a kidney stone that's obstructed, it is most likely going to be in this area. It is very unlikely for you to have a kidney stone that gets stuck in the ureter, because if it is small enough to pass through these, it's probably small enough to pass through the ureter as well. Now, how does it present? It presents with severe pain. I'm sure you've heard of this. It's colicky, and it's called loin to groin pain. It can be back pain as well. So why do you get this? The reason you get colicky pain, or colicky pain is kind of pain that comes and goes, is because the ureter, as you know, has smooth muscle around it. And one of its roles is obviously to transfer urine from the kidneys to the bladder. And as it contracts, it kind of helps with that role. However, if there is a stone there and it contracts against that stone, that's going to be very, very painful, which is why it's colicky. It also presents with loin to groin pain because the direction of that contraction is going to be from your kidneys to the bladder, or your loin or your flanks to your groin, and can also present with back pain because of referred pain. You can also have suprapubic pain depending on where the stone is, and dysuria. Some investigations to order. Firstly, you can do a urine dipstick, a urine MCS, as well as biochemistry. One thing you always look for is hematuria. Now, the reason you get hematuria with nephrolithiasis is because as your ureter is contracting against that hard stone, you will have some microtrauma to the ureter, and it can bleed a bit, which is why you can have mild hematuria, and that's mostly going to be microscopic. What I mean by that is, although you're bleeding, it's not going to be severe enough to change the color of the urine. But if you do a urine dipstick, you will see some RBCs on it. You can also do biochemistry as well as a 24-hour electrolyte collection of the urine itself. In terms of bloods, you can do an FBE. You can also do a UEC, check their renal function, and blood urea nitrogen to creatinine ratio. And if you remember our lecture on AKI, we talk about how this is a really wonderful test to differentiate some of our pre-renal causes of AKI from renal causes of AKI. As mentioned, some of the other reasons you might do certain tests, going back before I talk about imaging, going back to our main causes, you have calcium stones. Risk factor is hypercalcemia, so you can order or look at their calcium level. We have struvite stones, or our magnesium ammonium phosphate stones, and that are typically caused by pyelonephritis because of Proteus mirabilis, so a urine MCS. We then have uric acid stones because of gout, so we can look at serum urate levels. and take a history and ask about features of gout. In terms of imaging, I mentioned how you can do an abdominal ultrasound, and it's a quick, easy test to do at bedside. And you can also do a CT-KUB. An ultrasound is really quick and can demonstrate some obstructions. And the other big thing you can look for on an ultrasound is hydronephrosis. As you can imagine, if you have an obstruction here, you aren't going to be able to transmit much urine from the kidneys to the bladder, and you're going to have a backflow. That's going to cause hydronephrosis and can cause an AKI. So that's relevant to know. Now, what other things do you need to worry about when it comes to kidney stones? Going back to very basic principles, this person is going to be in a lot of pain. So please, we want to manage their pain adequately. This includes adequate fluids, strong analgesia. Usually we skip the Panadine and ibuprofen and everything. We move on to something stronger like oxycodone or endone. We want to give them antiemetics like ondansetron, which is also a strong antiemetic, because they also may be nauseous. And we might want to keep them nil by mouth if they may require surgery. Next, we also have to ask ourselves, why did they get a stone? And we'll cover the different causes that I already talked about. And in your head, you should be thinking about the various causes of kidney stones, and could this be something else? And then finally, you want to get rid of the stone, right? If you have a stone that's confirmed on imaging, our management is based on the size of the stone. So if the stone size is less than 5 millimeters, it's mostly conservative measures, and we expect the stone to pass on its own. And we do nothing pretty much. With 5 to 10 millimeters, we use medical expulsive therapy. So we give a medication called tamsulosin. And what tamsulosin does is it reduces the rate of urethral contractions. By reducing those contractions, firstly, you help open up the ureter a bit more, allowing for its transportation and eventual passage. And secondly, you also help with symptomatic control, because remember, the reason they're getting those strong colicky pains is because of the ureter contracting against the stone. And so by giving such a medication, you can prevent that from happening. Anything more than 10 millimeters, we start to get a bit worried that this is not something that can pass either conservatively or even with certain medications. And this is when we would consider some intervention. We can break the stone up, and that's what lithotripsy refers to. And that can either be done through shock waves or through a cystoscope. A cystoscope is basically when we use a small camera and a probe to go up the ureter and actually extract the stone. If nothing else works, we can also ditch that and go to what's called percutaneous nephrolithotomy. And that is where we go through the skin and actually access the ureter, make a slight longitudinal incision, get the stone out, and then close it back up. And that's all we had for kidney stones. I hope that helped. Again, any questions, please feel free to reach out. And as always, please look after yourself and please look after your loved ones.